was actually back in SA now. I was a friend and a colleague who is mainly based at Cape Urology Practice. He does sessions at Grooteskier. And yeah, he's our uro-oncology sessional consultant. Malcolm, if you can start presenting, please. Thank you.
Okay. Yeah, thanks, Sam. The topic that was chosen was called "What I've Learned Teaching Uro-Oncology Surgery," and it was something. I haven't been teaching uro-oncology surgery very much. I don't know that I'm any good at it, and I haven't seen the fruits of any of the teaching that I've done. So I thought maybe it would be best to talk about what I've learned learning uro-oncology surgery. And I've spent a lot longer learning surgery than I have teaching it, and I've been in all kinds of different learning environments, not just uro-oncology surgery, but from way back when I was a student and when I was a junior doctor, kind of learning surgery in different environments, in primary level, when there's not much supervision, down to academic secondary hospitals, and then big teaching hospitals, and in different types of environment. As I said, I was in Canada, where things are different, and just see the way some people teach things and the way some people approach learning things. And it's just really given me some insight on what I think is good and what I think is bad. And this is really about not what I've learned teaching it, but basically the approach that I'd like to take, or the things that I think about when I'm busy teaching people. And I don't know if they're right or they're wrong. And everybody is welcome to butt in and ask a question or put in their 2 cents worth, because like I say, this is probably just mostly going to be ramblings and musings about stuff that probably isn't really based on any kind of evidence. So this is my sort of disclaimer kind of thing. I haven't, as I said, taught very much, and like I say, they're just my observations mostly. Just right at the bottom there, I didn't choose the topic. I think John did, so I'll make the best of it, and let's see what we can say. So the first thing you do when you're getting a topic, when you're reading and researching, is you Google something. So this is an extract from the Journal of the American Medical Association from 1890 odd, and somebody was tasked to do this before me. This is the best method to teach surgery, and according to this chap, Professor Wright, you must have a large clinical observation before you start teaching it, and a vast operative experience, and you must be rapid in thought and good clinical judgment, and you must know what to do in an emergency. And although you may be influenced by other people's suggestion, you must rely solely upon yourself. And in many ways, a teacher is born and not made. So I can't tell you anything. You're either a born teacher or you're not, according to Professor Wright. But I don't know whether I agree with him. I think things have changed a lot in the last 130 years. But some people have realized that that's not always the case. So this is Helen Keller, similar age group, maybe a little bit later. But she realized that picking up skills is not just about reading a book and knowing the theory. And this is an apt quote about teaching and about surgery, which can apply to this chat. So this is something that I always think about, particularly when learning a motor skill. And this, I think, I first came across this, I think Andre van der Merwe was teaching a laparoscopic course, and this is something that he introduced me to. and this is really a motor kind of skill, but surgery in a way is, I mean, it is a learned skill. You do have to know what you're doing, and it's not just about the mechanics of it, but you can apply this method to it that, you know, initially, and especially when you're doing open surgery, you don't realize how complicated it is, and you think that you could do it because it seems fairly straightforward until you are tasked with, sorry, let me point with this one, so I'm pointing on the other screen. So until you're asked to do it, and you realize that actually it's harder than what you thought, and you realize that you actually are not good. And the more you practice and practice, the better you get with applying your mind, until eventually you are good enough at it to do it without having to really think about it. So definitely a lot of this applies to open surgery, a lot more to do with rote skills like, you know, laparoscopic suturing and things where you're learning, or cerebellum is learning something. This maybe doesn't apply as much to things like surgery, where you're actually doing things that your hands kind of already know how to do. It's just the method that you're learning. This is something that I've heard about a long time ago, and I think this applies in two ways to people learning surgery. It's the Dunning Kruger effect, and based on these two psychologists who published a paper back in 1999, and they studied a whole bunch of people in various, well, a cohort of people on various aspects, sense of humor and skills in an academic subject and so on. And they divided people into quartiles based on their experience. And the people in the lowest quartile, the people who were least experienced or knew the least, didn't quite realize it. And this does apply. So they overestimated their ability. So they thought they were better than what they were. And I think the underlying reason is that they haven't seen enough, they don't know enough to be able to assess their own skills. And they don't realize that they're incompetent because they haven't seen or haven't been experienced enough to see that the deficiencies in their skills. And this is something that we are aware of in surgery. Everyone knows about the second year registrar that gets left by themselves and decides to overstep their capabilities, and there's usually a disaster. There's a little slide that shows on the one axis their confidence, and on the other axis their competence. And right over here, when you know a little bit, you're a little bit competent, you are very overconfident. That's the Mount Stupid, people call it. And as soon as you have that one disaster, or you're left alone, this is usually when you do your first big procedure with the professor, and you think that you nailed it. The next time you're doing it by yourself, and you realize, oh my gosh, I have no idea what I'm doing, and it's a mess. You fall into the valley of despair, and then you realize this is the conscious incompetent. You realize, okay, I don't know what I'm doing, and then you have to slowly work your way up the slope of enlightenment. So that's something that I think of with surgery. Is a lot of teaching surgery is keeping people safe when they're at the top of Mount Stupid, and to actually bring them down to the point where they realize that they know what they don't know. And I think that's an important part of teaching surgery, is to get people to realize what they don't know and what the limitations are, and when to ask for help, and when to ask for an opinion on something. And yeah, that will get you safely up the slope of enlightenment. I think more applicable is the reverse Dunning Kruger effect. So that's, I think, something more informal. Some people think it's the imposter syndrome, where people who are experts or high achievers feel that they haven't, they don't deserve it, or that they downplay it. But in that original study, they noted that the top quartile of people underestimated their ability, probably because they assume that other people know what they know. And I think this is probably a lot more pertinent with people in teaching generally, but in surgery especially. People forget what it was like to learn, and they forget that they weren't ever able to do the things that they weren't always able to do what they could do, and they forget their learning period. And you often encounter this by the old surgeon saying, oh, you should know how to do this, or that young student can't even tie a knot, or they don't know what the CBD looks like, or they're incredulous that people are incompetent. And the usual talk is that that students nowadays don't know anything, and they're not committed, etc., etc. But I try and be cognizant of this, and realize that it wasn't that long ago where I was completely ignorant and incompetent, and it shouldn't be held against anybody. But you also shouldn't assume that somebody knows what they're doing, even when you shouldn't take anything for granted. So it's nice to be honest with people and say, listen, I didn't know this, or I learned this 2 months ago, and yeah, it's a good way of teaching. I think is just to bear in mind that people don't always know everything, and you just assume that they don't. And anything that you think somebody should know, you should just establish that by either giving them the opportunity to show you that they know something, or to ask them, or to tell them. Yeah. So this is something that somebody has overcomplicated. This is to do with microsurgery, that's combining some of these principles, but I don't know whether true life is as complicated as this. So I'm not going to get into this picture. So, the ways for learning surgery, I think there are two, and I've chatted to the guys about this. There are two main ways that I've seen, which the one is you're in a big teaching hospital and you spend 95% of the time watching the prof operate. If you're lucky, you get to open the wound, and if you're lucky, you get to close the wound. But the rest of the time, you're just watching the senior guy operate and do the surgery. And then one day later, when you're qualified, you can just copy exactly what you remember seeing. And I think that's probably one of the worst ways of learning, if that's all you do. And the second way, is being left alone. And some universities, the prof will show you one, and then you get left alone and you do all the rest. And that's usually when you're at the peak of Mount Stupid, and you think that you know it because, well, the prof has left you alone, and surely you must be competent enough. And I think that's the second most common way of teaching, and sometimes it alternates from one to the other. And the problem with being left alone is that you do learn from experience, but you probably don't learn the ideal way of doing things. It often feels good doing surgery like that, but I don't think it's ideal, because you aren't being shown the best way of doing things, and your small mistakes and your bad habits aren't being corrected. So if you think about something like tennis, or golf, which are in some ways similar. They a lot of theory and a lot of practice put together. You can't make a great tennis player or a champion golfer by watching people play tennis or play golf on TV. You know, you can sit and watch 1 million hours of Wimbledon and you won't be a much better tennis player. You can hit a tennis ball against the wall for hours and hours and you won't be that much better at tennis. The solution, I think, is to be coached. And I think that is, for the teacher, is the best, you know, the most difficult and the most frustrating and sometimes, you know, the most time intensive. But coaching young surgeons, I think, is the way that it needs to be done, the sort of primary approach. And it's really letting them do it, seeing what they know. You know, it's a back and forth continuously, and this is what I try and do. But you know, to go back and stretch the analogy more, you can't, if you are a top tennis player, you don't just spend your whole time being coached. You go and play matches, which is essentially being left alone, and all the top guys then go and watch TV and watch the other people do it and watch themselves on video and so on. So you do need to do all three. So once you've been coached, you probably do need to be left alone from time to time to realize that you you know, that maybe you're not as good as you think you are, or maybe to give you some confidence, maybe to teach you new insights. And then also going back to watch the prof operate, or to watch the experts do it on YouTube, or going to a different center to learn. If you watch the experts do it before you have ever tried it, you don't have the insight to realize what they're doing differently, you know, how you would do it. You don't pick up the tricks as easy because, again, you don't have the insight. So going back and operating with other people, once you're already competent, I've found a lot of value in it, and you always learn. And that's the other thing about this surgery, or surgery in general, is that you never stop learning it. If you paying attention and you're listening to the people, it's something you'll learn and refine going. So being coached, I think, is the best way of learning surgery, but you do, it's obviously something, it's not the only way. So just a sort of bunch of random things of you know, what I think about when teaching surgery. It is always, you're learning it, or in our environment especially, patient safety is the most important. So there is a certain level of competence that people have to have before they do come and operate on real people. And you know, you can have teaching, but obviously the patient has to do well, and you can't teach at the expense of somebody else's health and well-being. So you know, there's a limit, and you must always be aware of that. The other thing is that everybody, so from the 5th year medical students that are in theatre to the registrars and the MOs, you don't really have to lead the horse to water. You know, it's everyone there usually wants to learn, and they are eager to pick up tips and tricks. So nobody really goes to theatre and says, oh, I'm not interested in learning a new trick, or I'm not interested in learning a new way of doing something. The students, you know, they'd love to scrub, and they'd love to be shown how to put a stitch in here and there. So it's a lovely place to teach, because everybody is eager. And even if they don't appear eager, so the students that are sitting in the corner are probably sitting in the corner because nobody's invited them to scrub and close the wind. again, never assume that anybody knows something. You'd be very surprised at what people don't know. Again, that's the reverse Dunning Kruger effect. There's a lot that I don't know that I don't necessarily want to tell people, but you try and be transparent. And if you don't know something, then you can always ask yourself, and it, I think, helps a lot. The other thing is sort of related to the eager learners, is that all these surgical things have great stickiness. It's not like learning the causes of hypercalcemia. If you show somebody a method once, you don't usually have to show them again. Especially if it's a little, a good tip, or a way of exposing something, or a trick, which surgery is a lot about little tips and tricks like that. As I say, you only have to show them once and they'll remember it. So it's a great place to be teaching, because you don't have to teach the same thing over and over and over again. People remember practical things, which is nice. And a lot of surgery is about knowing the anatomy, and it's an easy thing to do as you operate. Point out the anatomy, and something I like to do, and I think the people who've heard it before get tired of me asking the same things over and over, but and it's simple and reproducible, and it will help people in future. So you're always seeing the anatomy during your surgeries, so point it out every time and watch it. The other thing that I've seen in many places is that, they'll teach the most senior person, and everybody else has to sit around and watch. But I think teaching everybody progressively is important. So pre-enabling people to learn. So to get to the next step. So for example, the fourth year students need to go to that basic surgical skills course, so that when you invite them to put a stitch in, then they know how to hold a needle driver and how to tie a knot and so on. And similarly, the first year registrar has to know how to close the sheath, because when they're a fourth year registrar, then you can't be surprised if they can't do the whole operation, if they haven't been shown how to do the sheath. So yeah, everybody should be taught to their ability as you go up, and then you don't have to teach the most senior person everything from scratch, which you can't really do feasibly. If you have a final year registrar who's incompetent, it's very difficult to catch them up, which I've seen firsthand, and it's unfair on everybody involved. And again, this is going back to the golf or the tennis analogy, coaching people through, and also, as you learn, I've seen junior guys, or the way it's worked in the department, when you're in your first year, you get taught how to do the transurethral surgery, the endoscopic surgery, sometimes by a more senior registrar. So I've found that teaching people, you kind of have to break it down for yourself, and that insight probably makes you better. So I think teaching other people is a good part of being taught. Yeah, so I think that as a cycle, not moving from one stage to the next, but sort of doing that in a mixed up kind of way. And of course, reading all the books, knowing the operations, how, what Hinman says, what each different volume of Hinman says, and the BJU articles on how to do a surgery, and endoscopic and laparoscopic and robotic surgery. There's so many videos out there that are great to watch, before you start that type of surgery, while you're busy doing it, even once you think you're good, to go back and watch videos, especially, as I said, for the laparoscopic stuff, is really, really helpful. But there are videos available of open procedures as well, which do help at every level. So I've found those useful throughout my career. So things that more specific to uro-oncology that I've thought about in open surgery specifically, these are often quite complicated cases, or they can be, and I try and get in the habit of talking a lot beforehand and talking a lot afterwards, so sort of debriefing afterwards as well. And a lot of surgery, especially the open surgery, is not just about the procedure. It's about the decision making, preparing your equipment and your sutures, talking to the nursing staff and making sure they've got what they need, talking to your trainees about the positioning, how you're going to position the patient, how you're going to obtain exposure, and then what difficulties you can expect. And always go through the scans with everybody and talk about it, because there's often it's a lot easier to talk about things, or to set up and to say, well, when we get to this step, then this is what it might do, and this is how we might handle it, so that you don't have to stop the operation to talk about it in more detail. You can say, remember, we said this, and so on. So it's sort of, I've found it very helpful to do it before. And then afterwards, I try and always debrief. It's not always easy to do, but just to give feedback to the person who was learning, just say, well, you did really well, and it was a tough case, but you handled it, and this is what I thought we could have done differently, or this is what I saw that you struggled with. And so that sort of thing, rather than criticizing in the moment, you give somebody an opportunity themselves, and then you give them feedback afterwards, which I think helps very well, and just to give an overall appraisal. The other thing is that a lot of the oncology surgeries are pretty routine, so like a cystectomy or a nephrectomy, or a laparoscopic nephrectomy, or a prostatectomy. The steps are always the same, so just make sure people know the steps and how to complete the steps before moving on to the next one. But when you have a difficulty, then just teach the principles of handling those difficulties. And that's, I think, if you know the steps of an operation and you know how to handle the difficulties, then you're 90% of the way there. And the other thing is that I've seen a lot of the same surgeries by a lot of different people, and it's, I think, quite important for trainees to know different ways of doing things, so that they can get out of trouble if they run into problems with one way, and they can also choose what's most efficient in their hands and what they're most comfortable with. So I try and show people different ways of doing things, and to kind of make them aware of the pros and the cons of each of those things, in my experience. And people just need to make up their own minds on what works best for them. And I think things that maybe not well taught is a little inaccurate, things that people end up having to learn the hard way later on. It's often you learn the steps, and they show you, when it needs to be done, where and how. But things that people sometimes only learn once they're left alone, and they're all on their own. The one is getting the exposure yourself. Often the consultant that you're operating with is the person that establishes who retracts what and how you see what. So I do try and teach people how to get good exposure in their surgeries and when to recognize when they are operating with poor exposure, because that's the most important thing for good open surgery. The other thing is managing your scrub nurse, to communicate well with them, to tell them what you need next. So to think 2 steps ahead so that they work more efficiently, so that they know what's going on, and that they're part of the team. And I think a lot of this is actually empowering the trainee to take charge of the ship, basically, because that's what you need to do one day when you're leading a surgery, that you need to be the sort of captain in charge. So also managing the assistants. If the consultant is assisting you, you need to be able to tell them what to do. It's also why operating with the juniors is also important, and it's a good skill that again, often people only get to once their prof is not there anymore. So yeah, so telling people what to do, telling what hands they must hold certain things in, how they must retract for you, you know, where they must cut, I think is something that we need to get people aware of and doing earlier. And then communicating with the floor staff and the anesthetists is also important as a surgeon, and to get people to handle themselves well and to communicate well, let people know when there's bleeding, let people know when you're having trouble, and you know, maintaining a good relationship across the screen is a skill that will make for good outcomes, but is often not taught. So that's, yeah, my ramblings in a nutshell. I don't know if anyone agrees with something or disagrees with anything. I'd be welcome to take comments.
Thank you so much, Malcolm, for such an insightful presentation. I don't know if there's any questions for Malcolm on the floor. Yeah, I must say, Malcolm, some of us, you know, okay, there from Justin, the comment. I must say some of us would not agree you much in what you've just said earlier on in the slides, that you're not quite sure if you're really a good teacher or not. I think you know, some of us have actually benefited in all the knowledge and experience, surgical experience you actually gained in a uro-oncology fellowship from Canada. And I think we greatly appreciate the contribution that you know, that you have on our unit. There's actually a few things that have actually changed, you know, in how we approach surgical cases. You know, I mean, for example, you know, we do our cystectomies now extraperitonially, and we've seen how that sort of changes the outcomes in the patients. As you all know, the main thing is really an alias, which we're seeing less and less of that. Yeah, no, Lisa's got a question. Let's just see what she has to say.
Hi, morning. Can you hear me?
Hi, Lisa. Yes,
morning.
Yeah.
Listen, I think more a comment than anything else. You know, I think I've had the privilege of seeing you grow from being a trainee to a unconsciously very competent surgeon and teacher. And I think the thing which really makes a very good surgeon, or sets apart from you know, the surgeons which, you know, kind of plod along in their careers, that if you have a humility about the way that you work and the way that you kind of deal with people around you, you never stop learning. And I think that's one of the privileges of being a teacher, is that although you believe that you're competent at a certain operation, being exposed to the trainees that come through your hands, you know, there's going to be the genius or just the very practical person that's going to teach you something new every now and again. And I think that actually really builds upon one's own skills as well. And I think that's been my experience. I think I just want to thank you for this lecture, because I think it has given me quite a lot of insights. I think I might have the opposite Dunning Kruger effect, and points. I can't understand why the C arm's not there every week, you know. So I will take some lessons from your lecture. So thank you very much, Malcolm.
No, it's a pleasure. Yeah, just that one comment of Lisa, I think, is really important. That to go back to that overused kind of airline pilot analogy, the Malcolm Gladwell story, that having a flat hierarchy in theatre is really important. There must be a hierarchy because the buck stops somewhere. But having that flat hierarchy where a trainee can teach you and realize, okay, he can speak up and say, listen, I think there's a better way of doing something, and listening to them. And yeah, I've learned a lot from people who technically were junior to me. Yeah.
There's a question for you. Any plans to start a Euro-Oncology Fellowship in South Africa?
Yeah, I don't know. No plans. Short answer, no. But I think it's something that probably needed, I suppose. So maybe one day.
Yeah, I think that'd be nice. I mean, I think we've got a lot of expertise in South Africa, pediatrics, and urology. I think maybe in the future we'll get there. Thank you so much, Malcolm, for sharing all this experience, and again, an insightful presentation. We hope you're gonna stick around for the next talk. It's a Euro-Oncology talk.
I'll do my best.
Thanks.
Yes.
Helene, do you mind loading your slides, please?
Yes, I just